Hi, everybody. Thanks for joining us today for our Rural Health Work Group. My name is Rachel, and I am a Site Engagement Coordinator with MVC. It is my pleasure to be facilitating the work group today. This is our agenda for today's work group. We're going to go through some of our housekeeping and P4P credit reminders. Then we will have a presentation from MyMichigan on their sepsis discharge planning follow-up initiative. Followed by a little discussion time with some Q&A opportunity. And then we'll go through at the end and let you know about some of our MVC upcoming events and updates. So some of our housekeeping items to remember, we do record our work groups. So if you could please make sure your microphone is muted throughout the presentation, that would be great. It helps reduce any background noises that might occur. We will also provide the recording of the work group at the end when I send out the email with the details and the survey link for our post-work group survey. And then feel free to put any questions you have in the chat throughout the work group. We will look at that during the discussion time and make sure to go through each one of those as well. For our P4P participating sites, just a reminder that we do encourage active participation. So please make sure to listen closely and ask any questions you might have or give any input during our discussion time. It's greatly appreciated. And then also to finish out the work group for engagement points, you will need to fill out a post-work group survey. We will put the link in the chat at the end, but then we will also share the link in the email at the end of the day when I send that out to you all. All right, so today's presenter is Stephanie Pins-Schallip. She is the Director of Value-Based Care at MyMichigan Health Center. Stephanie is primarily focusing on improved patient outcomes and reducing unnecessary costs. She grew up in Eastern Upper Peninsula, obtained a Bachelor of Science in Engineering and Technology from Northern Michigan University, and has a Master's in Healthcare Administration from Central Michigan University. Her background is in healthcare quality, risk, and compliance. She is co-leading the health equity initiatives for MyMichigan Health and has found that patient advocacy extends beyond the walls of the hospital into our communities with community partners. Stephanie is a Team Steps Master Trainer, Lean Six Sigma Green Belt, and holds a Certified Professional in Healthcare Quality certification. With that, I'm going to be passing the reins over to Stephanie for her presentation.
All right. Well, thank you very much, Rachel, for that. And good afternoon, everybody. I don't know if you all are sitting in air conditioning. I'm in like the 1958 portion of the hospital that has no air conditioning. So the makeup and the hair just were not cooperating today. I'll apologize ahead of time for that. I have my window open, so I should be good. But I appreciate you guys asking me to present on some of the work that MyMichigan has done in kind of collaboration with another CQI, which is HMS. I'm sure there's maybe some people on the phone that participate with both MVC and HMS, and this just kind of is bridging that gap between them. So thank you. You want to go to the next slide? So a little bit about MyMichigan Health. We have 10 hospitals and one kind of town center. It's not really considered a hospital, but we list it as a location. 4 of those are critical access hospitals. And I know MVC has been really talking system and how to promote system and use a system to benefit some of those smaller hospitals. And I thought this was a really good example of how some of our work in the HMS space not only impacts and benefits those hospitals that participate with HMS, but participate or that benefit some of those critical access hospitals that don't participate. So this is kind of our locations. We're on the eastern side of the state, everywhere from Sault Ste. Marie, where I physically sit, all the way down to Saginaw. Next slide. Like I talked about, MVC is a CQI, and those probably participate with MVC, also participate with HMS maybe. which is the CQI Hospital Medicine Safety Consortium, really focusing on antibiotic use and sepsis in the past, some mid and PICC line initiatives, kind of switching over to critical care settings. So that's some work that's going on there. But for the sepsis piece of it, there was one requirement that came across in 2025 and 2026 around increasing discharge and post-discharge care coordination for those patients that had been diagnosed with sepsis during their stay. So they're specifically looking at discharges between 5/7 and 7/29. That's the performance period they're looking at. But obviously this makes sense for our patients. And one of the things that MyMichigan is trying to do when we take that system approach is not just work on one performance improvement initiative for one location. We're really looking at how can we implement it so it supports all of our hospitals, knowing that those hospitals with very limited resources, like our critical access hospitals, probably need the support more so than some of our bigger campuses. So keeping those in mind as well. Next slide. So current state of our discharge care coordination for patients diagnosed with sepsis. Previous to this performance improvement project, staff would need to manually choose education to print upon discharge. And patients, if they have a question, post-discharge, they're calling switchboards, they're calling around, trying to find information to get through to the right person to have those questions answered. And if they wait long enough, we know they're going to be coming back into the emergency room for something maybe basic. So really, that's what we're looking to do, is support those patients upon discharge. If they have questions, anything to keep them healthy and well and out of the emergency room, and obviously out of another readmission. Next slide. So the goal for HMS was to, one part of the goal, there's actually two pieces of it, but I'm just going to cover the one today, is provide a hospital contact number included in the discharge paperwork. And in order to pass that measure, the phone number must be prominently displayed on discharge paperwork with instructions to call the number if the patient has any questions or concerns or they have any complications post-discharge. That phone line must be manned 24/7, which obviously we run into issues in our critical access hospitals and some of our smaller acute care hospitals as well. You can include either the PCP or specialist number, and that number must connect the patient to a provider within 1 hour. And again, for a critical access hospital, this is a tall order to hit. So those are the HMS requirements for that measure. If you go to the next slide. So we started a performance improvement project. We call them 8-3s, and got to doing our fishbone and digging into, what is our barriers to being successful, and some of the barriers we found. So we said, okay, if we printed out the secretary phone number for every med-surg unit, we know that we don't have secretaries on every single unit to answer the phone. We know there's going to be times when someone doesn't answer that phone. So that was a barrier. We don't have the ability to schedule on weekends, and we cannot schedule VA appointments. There's no standardized process for follow-up phone calls. And PCP is not always updated upon admission. So we were kind of limited with that. So we got together and said, okay, well, these being our barriers, what are some potential solutions? And the team really came up with 3 good ones. We can add a transfer center phone number to utilize on-call hospitalists 24/7 as a contact. We could increase the number of follow-up appointments made prior to discharge, and we can add the continuing care clinic phone number. So the team really came up with 3 viable options for MyMichigan Health. When we got into it and started looking at what is going to obviously be the most appropriate, less kind of manual operation, we decided that adding that transfer center phone number, which is manned 24/7, and what this transfer center is it's kind of a bed placement air traffic control. So amongst all 10 hospitals, if we have patients transferring from one to another hospital, this phone number is manned by a nurse and a couple of other non-nurses to say, we have beds available here, we have beds available here. So they're kind of the air traffic control of the health system. but it's manned 24/7 and they have a little bit of capacity. So their director thankfully stepped up and said, my team has a little bit of capacity. What type of volume are we looking at here? And we said, we really don't know what kind of volume. We've got to really put it out there and test it to see. But what we did was we said, okay, this is what we're going to test and this is what we're going to work towards. Next slide. So we came up with that performance improvement plan. We were going to meet the measure by providing a hospital contact information at discharge and an AVS. So every time a patient is diagnosed with sepsis, so we came up with a plan to make sure that every time a patient was diagnosed with sepsis during their inpatient stay, an AVS would automatically print upon discharge that would have this phone number prominently displayed on it. So we defined our new standardized process, adding a dedicated phone number to an after visit summary at discharge, utilizing the on-call hospitalist and the 24/7 contact. We did name a executive sponsor. So Dr. Berg, who is our chief medical officer, was our executive sponsor and kind of supported this work, making sure that we had the hospitalists on board because that was a very key piece of it. Hospitalists, when we first approached them about this, they were very hesitant about being responsible for the patient after discharge. And this was kind of a big hurdle to get past with them. And it took Dr. Berg and it took our hospitalist leader to kind of have those conversations and say, well, you're really just following up on basic, probably medication didn't get sent to the right pharmacy. It says I need medication. It wasn't ordered. Type of things that hospitalist should really be responsible for following up on. And once they kind of heard that and understand that, they were on board. Still have a little bit, I'm not saying it's all perfect, but we are making some headway and those hospitalists are starting to understand why this is so important to the patients. We did some education. This go live date is not the right go live date. It was our original go live. Because of the hospitalist, we delayed a little bit until 7/11. So that was our actual go live date. Next slide. So when we went to design our process, we created an algorithm for the system, not just for one member location or just for those hospitals that are part of HMS. We wanted a standardized process for all patients across our system. So we made sure that it encompassed every single hospital in MyMichigan. The process utilizes, again, that transfer center with communication through PerfectServe, connecting with the on-call hospitalist provider. So as kind of that air traffic control, they know who is on call for the hospitalist at that member location, and they can send them a PerfectServe, which is our HIPAA compliant text messaging. I did, just as kind of the leader of this A3, asked to be copied on all of those just so I could see what types of questions patients are calling with. And I will say that transfer center was nervous about the number of phone calls, but as of today, they've maybe only seen at 4 calls at the most. So not a high number, but still for those patients that called, they got answers within 1 hour. And that's worth it right there. So we did look at discharge diagnosis focused on A41-9 sepsis of an unspecified organism, the R6520 and the R6521. So those are the diagnoses we put in Epic to say if they're diagnosed with this, you need to print that AVS automatically. We don't want to rely on staff having to click a button and remember to do that. One of the things as we kind of continue the work, the performance improvement, we've identified a couple of other ICD-10 codes that we can add to that just to kind of make sure that we're capturing more sepsis patients upon discharge. Okay, next slide. So again, just a little bit more into our process. After the patient is discharged from the hospital after a sepsis diagnosis, that patient has any questions at all, there is that phone number that they're going to call. The call goes to that 24/7 staff bed placement line. Now, I think it's important to say that There are some nurses that man this line, and there are some non-nurses that man this line. This line is not a triage line. That role is not to triage the patient and see what they need. Obviously, they need to take some information from the patient. So they're getting their question, they're getting their name, the place they were discharged from, so they can look them up in the system. They have access to the system to see, where they were at, when they were discharged, and who the hospitalist is to call. So that they'll get that information, send a perfect serve to that hospitalist or an APP for follow-up, but it is not the role of that person answering the phone to triage that patient. We wanted to make sure that was very clear. They are only getting that patient in touch with the hospitalist. And obviously, the hospitalist will be able to determine, yes, it's a medication issue, I'll call it in, or no, you need to go to the emergency department right now and give that feedback. Again, they'll send that perfect serve message. I asked to be copied on it just so I could see what kind of questions were going to the hospitalist and how appropriate they are. One of the questions that came from the hospitalist is, how long are we responsible to answer phone calls? If it's 3 weeks post-discharge and that patient has a question, what is our response? That's one of the things we're kind of working through right now, is to kind of put a time limit on it to communicate to them, we want you to still kind of support the patient within this, ideally 30 days post-discharge, maybe a little bit more. But then at that point, it's, you need to contact your PCP, or if you don't have a PCP, we can help, get you in touch with one. So that's a little bit of more improvement work going on in this process. And then the hospitalist follows up with the patient. They're provided a phone number and they can call that patient within the 1 hour mark. Next slide. So this is a picture of our AVS that goes out, and you can see down at the bottom, we have it. If you have any questions at all on your discharge, please call this phone number. We did, even though it's bed placement, we did create a dedicated phone number. So when they call this line, we know that the patient is calling the sepsis post-discharge phone number. So we can at least go back and run volumes of the phone number, and so the bed placement staff know that this is an incoming call for a sepsis follow-up concern. We have one number for the entire system. We don't have different phone numbers for different locations. That really is effective in making sure that we're reducing the burden at every member location. We don't have to duplicate efforts. We just have one person manning that phone, and that bed placement person has access to the on-call schedule for all member locations. Next slide. So a couple of the examples of phone calls that we've received is, we had a patient diagnosed or discharged after a spider bite, was given supplies for wound care, and was told to take an antibiotic. After getting home, the patient realized she was not given any prescriptions for the antibiotic. Upon follow-up, the physician responded that, yep, it was missed, and they're able to send that right away to Meyer. And that patient got feedback that that script was called in within that 1 hour mark. Next slide. Another example is, the patient was discharged and thought they needed to have a prescription for antibiotics sent to the pharmacy. They were looking for it, they were waiting for it. So they called to follow up, and the physician was able to verify that the patient, in fact, did receive the 6 days prior to discharge, so they didn't need anything further. So, just kind of shows communication, right? Communication with the patient. Thank goodness they saw a number, they called, they got the follow-up they needed, and got everything clarified. So the patient received that quick response, which not only is safe for the patient, it also helps in patient satisfaction as well. So with that, I guess if there's any questions. It by no means is a perfect process. We're still improving it, but I'd also love to hear maybe how some other hospitals are doing this work as well.
Yeah, thanks, Stephanie. All right. Feel free to put any questions you have in the chat. While we're waiting to see if people want to put something in there, I do have a question about kind of your future plans for the initiative. Will you be doing any sort of like feedback with the providers the hospitalists that have been taking the calls to see how they're handling it and how that's working for them. And then likewise for the patients that are using the phone line as well.
Yeah, so when we initially launched this program, we set follow-up phone calls to meet with the leader of the hospital's group, Dr. Berg, to hear what kind of feedback they're getting. Just so we're keeping in touch and we're rounding intentionally with them to hear about maybe what their issues are. Same with the bed placement staff to find out what issues they're having. We do ask them to kind of log some information so that we can see, if they feel there's concerns about volume or if the numbers are higher than what we thought they would be. We have data to go off of. But yeah, I think part of it is just that intentional rounding after it's launched for 3 months. Just that 90-day follow-up.
Yeah, so you said that it launched on June 1st, right?
Yeah, launched on June 1st, didn't really go into effect until was it June?
A little bit after.
Yeah, a little bit after.
Okay.
Yeah.
Very cool. Well, there aren't any questions in the chat. I don't know if Jessica or Emily have any questions they might want to ask.
I just saw, go ahead.
One just popped up as I said that. Kimberly asks, are you aware if this process is used for other diagnosis or looking at using for other diagnoses?
Yeah, so I'm not aware that this process is used for any other diagnoses, but obviously, we all are working on readmissions. We're all working on mortality and pneumonia, congestive heart failure, any of those chronic conditions, this type of process would support. It kind of runs into, we have ACOs in some of our hospitals that are making those discharge follow-ups as part of their work. So I think further alignment with them would be beneficial, but they are not focused on sepsis. That is not one of the chronic conditions that they're following up on. So this is kind of a first off for them.
Okay. And then Shelby asks, is your hospitalist group hospital employed? Would compliance of this process differ if the physicians were privately employed versus hospital employed?
Yeah, so we have a mix. The majority are employed, some are not employed. We do have a CMU group of physicians and we do have some private physicians. We rolled it out as kind of expectations for our hospital and our hospital processes. Obviously we don't have much leverage over those non-employed physicians, but we can provide feedback. So part of me getting copied on the perfect search is to see if we don't get a response from those physicians. And obviously we would follow up with them personally, but the expectations are out there for anybody taking care of patients within our walls.
Megan is asking, you mentioned you utilize Epic to flag specific diagnosis codes, so you aren't relying on staff to catch these patients on discharge. Our EMR is limited and unable to complete that function. Did you explore other options for ensuring sepsis patients weren't missed on discharge?
So that's one of the continuing improvement processes that we're looking at. We've got a couple of HMS abstractors, abstracting in this data all the time. And one of them brought forward a couple of other sepsis diagnoses that are not added. So that's one of the things that we are going to be looking into. Right now, we do not have a process if it's not coded on the chart prior to the patient leaving, or if Epic isn't able to print it itself. Obviously, staff can go in, click that AVS for any patient and add it to the education, but we don't have a solid fix yet for that.
Okay. And then Jill asks, can you talk more about how you gained support from the on-call providers to take the calls?
Yeah, so I can't say enough about getting Dr. Berg involved, our chief medical officer, and having an executive sponsor. I think, as quality members of the hospitalists listen to us, but we are not as, I don't want to say respected, but the same as the CMO coming in and saying this is an initiative that's important to us and that we're going to do. So I think just having the chief medical officer be that one that says, no, we're going to figure this out and we're going to do it, is imperative. So our team put the process together, but he really rallied the troops and made sure that, they understood the why and, the how. So get an executive sponsor. I found every time that's the best way to make some of this stuff happen with the hospitalist groups.
Yeah. Did you have Dr. Berg involved like early on in the planning stages?
Yeah, so we went to an HMS collaborative wide meeting and they put the data up there. And when they unblind data and you see your hospital not where they think it should be, right? So that's why unblinded data is so important in that setting. It is for improvement. He came back and said, nope, we're going to do this. So,
All right. Good to know. All right. Thank you, Stephanie.
awesome.
Any other last questions? It's like the chat is quieted down.
Well,
All right.
thanks. Sure.
Yeah, absolutely. It's been great having you present. There was a lot of good information. I think folks will be able to take that back to their sites and hopefully utilize that for their own site. All right. We are going to move on now to upcoming work groups. So we have our next work group on Thursday, July 23rd. This is going to be a post-discharge follow-up work group, but we're going to be doing a walkthrough of our MVC follow-up push report. This report went out in April. So we'll have a joint presentation between myself and Janet, one of our data analysts, where we will walk through the site version of the follow-up report and then also the system version of the follow-up report. This will be a blinded version, but it should give you a good idea of how it got all put together. And then after the walkthrough, I'll be kind of going through some different actionable takeaways that folks might be able to use with those reports. So we hope to see you guys there. And then following that work group will be Tuesday, August 11th. It is our preoperative testing work group. We will have a presentation by Henry Ford Health Genesis, and they'll be going over their preoperative testing initiative. And then some upcoming events. Just a reminder, we do have our fall collaborative wide meeting presentation proposal deadline coming up on July 28th. So if you have an inkling or an idea that you'd like to present on something interesting at our fall collaborative wide meeting, make sure you get that submitted by July 28th. If you have any questions about what kind of presentation we would be looking for, feel free to email us. We are happy to answer those questions. And then we're always looking for presenters, so feel free to send in any other presentation ideas you might have through the link. It'll be in the slides and in the email I send out later. We're always interested to hear from our members, and our members love learning from fellow members, so don't be shy. All right, thank you so much, everybody. Emily is going to put the link in the chat for the post-work group survey. And then I'll be sending out the email later today with the rest of the information and the recording. Again, thank you so much, Stephanie, for presenting. We really appreciate it. Hopefully everybody learned a lot today. So have a great rest of the day.
Stay cool in there, Stephanie.